Hey everybody, my name is Paul Singh. I'm an anterior segment surgeon and glaucoma specialist out here in southeastern Wisconsin. And I want to welcome you to the Innovations Journal Club. That's a program where we're going to be discussing podium data, peer-reviewed literature, and actually OUS experiences related to innovations and technologies that we offer to change the way ophthalmology is practiced in the real world. Again, I'm your host for this episode, and today we're going to talk about advances and innovations in the cataract IOL space. And I'm happy to introduce our guest today, James Katz from Des Plaines, Illinois, our cataract refractive specialist. How you doing, man?
Thanks. It's great to see you out here, and I'm excited to talk about this topic. It's a very relevant topic right now.
We're so lucky to have so many options now. Our toolbox is expanding every few years now, it seems like. It's hard to keep up. And so there's a couple of papers I want to talk to you about and get your thoughts on it. And what does it mean kind of in the real world? How does it affect us in kind of our daily functioning and daily treatment options? And so I'm just going to talk about a paper real quick here. It's a paper that was done looking at the new iHance monofocal IOL by Offarth, which was published back in 2021. And it's a lens, for those of you out there, it's a lens that's a monofocal IOL. That's a single-piece acrylic hydrophobic IOL. But tell us about kind of the design. Are you familiar with kind of how it is different than a standard monofocal IOL?
Yeah, we talk about different types of lens. Of course, multifocal, intraocular lens, extended depth of focus lens. This is kind of more of an enhanced monofocal lens. So the design of the lens, they deal with asphericity, certainly, but it's a kind of progressive power change as it advances towards the middle of the lens. So it's really a different design. It's a very smooth, seamless transition of this design lens.
So it is a monofocal lens. There's no diffractive properties to it, no loss of contrast.
Correct.
From it as well.
And that's what part of the study shows is, are there contrast differences in this lens? So real life is what we're concerned about for our patients. Does this affect them or not? So I think that's very relevant. So no, there really doesn't seem to be contrast changes with this kind of lens. So that's excellent. For a monofocal lens, we want excellent quality of vision, but can we get an extended depth along with it? And that's what this lens gives, and that's what the study showed.
Real quick on the data, it does show us, and if you could kind of walk with us through this as well, we looked at the IC-BU, which is the new iHance monofocal lens, compared to the ZC-BU, it's a standard monofocal lens. And what we're finding here is about a line better in intermediate vision, pretty much.
That's right. So whether it was looked at different levels of photopic or mesopic light conditions, you gained about a one line of vision. So that's relevant vision change in a monofocal lens.
So tell me, what do you mean by relevant? Like, what does that mean for real world? Like, if you're sitting at your patient in the room, you say, Mrs. Smith, because of this lens, there's a chance you can get X, Y, and Z better options for your daily function. What kind of functions do you think?
So I think it's more for intermediate vision, but we deal with intermediate vision all the time. We're talking about using a computer, tablets, iPads, seeing the dashboard, seeing our food when we eat. Very relevant things in this day and age. It's what people want. That's what you get out of a line and a half of vision.
Yeah, no, that's a really good point. I think a lot of our iPads and everything else that people are using, computer work, dashboards in the car, those are the kind of things that I think people really want to have independence from. And if they have to wear a pair of reading glasses, let's say over the counter for close-up, they're willing to do that a lot of times. And the key is not compromising quality of vision, right? Uncorrected vision and distance-corrected vision. So let's talk about that. In this slide here, we're looking at the differences between this lens and the standard ZC-BU here. And any thoughts on the differences? I mean, pretty non-inferior. Anything thoughts that bring up to you?
It's relatively the same. There's maybe half a line difference in vision, but we're talking about 2016 versus 2020 vision.
Sure.
So we talk about that loss. It's insignificant, in my opinion, that loss. But the quality vision is excellent in all these lighting conditions. Again, photopic lighting conditions, mesopic low light conditions, bilateral, monocular, and one-eye conditions. So again, the relevance of this is that the vision is quite good for distance. You get extended depth for intermediate vision. Patients love that without the loss of contrast.
Yeah, and that's on the last line there. Binocular, mesopic, low contrast, corrected distance vision is no difference. And that to me is really important. And I think from a patient selection, so we have data that shows us we get about a line better intermediate, no loss of contrast or quality of vision compared to the standard monofocal lens. So what does that mean to you in terms of patient selection? What lens or what type of patients would you feel comfortable offering this in? Are there any kind of call-outs or watch-outs?
So we talked about the fact that in low light conditions, so pupil independence. So we talk about night driving, those kind of things. Patients don't want to be nervous about driving at night, even if they have excellent vision during the day. So that loss of contrast at night could become significant for some of our patients. They want a seamless transition from day to night. intermediate to distance, those kind of things. So the patient I would choose with this kind of lens is a patient who would be a great monofocal lens candidate that would appreciate an increased intermediate range of vision, who doesn't want to accept loss of quality of vision, be concerned overall with external or extensive glare and halos at night, those kind of things. So a functional patient who likes to go out, do things, drive at night. So that kind of functional lens or that lifestyle lens, I think.
Yeah, I think for me personally, I'm a glaucoma specialist as well, so I see a lot of patients with ocular surface disease where glaucoma, early loss of contrast is one of the earliest signs of glaucoma. Having a lens that doesn't affect contrast sensitivity, I think is really important from my perspective as well, but also giving them a little bit of some of that enhanced intermediate. And again, I'm not sure what your thoughts on monovision. Are you using this lens in a sense of a bit of minified or mini mono, or are you doing it plano for both eyes?
I think one of the nice things about this lens is you can use it as a monofocal lens, not even have that much of a discussion with the patient. It's not technically a new technology IOL in that category. So there isn't necessarily an upcharge for a patient in this case. So expectations can be such that it'll be extended vision, but you don't even have to really discuss that. What you're placing is an excellent quality lens with similar differences in contrast, therefore essentially no loss of contrast in the lens. So you're putting a high quality monofocal plus lens in. And so to a patient, when you explain how they're not going to have the downsides of problems with this lens, I don't think we have to discuss the upside so much. It'll work itself in. If you set expectations such and start talking about what they're going to gain by this lens, you're setting the bar higher. So I think, yeah.
No, that's a great point. I'm glad you brought that up because this is not an AT-IOL, and so therefore we're not technically upcharging for that lens or the process around it. So it is a standard monofocal lens in terms of reimbursements and cost. So that's the point is more your perspective as a doctor, what you think is best for the patient versus telling them I'm putting a lens that's going to give you more intermediate range of vision as well. Now there's different ways people work around the packaging, and if you do, let's say, a toric lens. So I know that there's a toric version of the iHance as well, where you can upcharge because it is an AT-IOL. In that sense, you can start to talk about ranges of vision and the benefits of it as well. But I think the fact that there's no downside from a quality of vision perspective, and it's considered a standard monofocal lens in terms of a status of AT-IOL, I think you're absolutely right. Just kind of telling this is the best for your eye. I think it's going to give you good quality of vision, and leave it at that as well. Now, would you target at all, even if you're not having that discussion, would you target a little bit of mini mono and like minus a quarter or minus a half in the other non-dominant eye with these lenses?
Because this type of lens is a lens put into the patient, don't have to have that much discussion, I typically don't target. I'll go pretty much first minus for the lens in each eye, see how they do on the first eye, usually the dominant eye first, and then go from there if they need a little more enhancement for intermediate. But again, this type of lens we're ending up if the patient didn't desire a multifocal lens, didn't desire a more enhanced or EDOF lens, more powerful EDOF lens. So this is a patient who will be satisfied with high quality vision, basically our monofocal patients, but we know they're going to get a benefit, extra benefit out of it, even without the toric correction. So I think that's that sweet spot for this kind of patient. This is the new standard for monofocal lenses, and I think this will continue in the future of that category of monofocal kind of plus or enhanced monofocal lenses.
And let's bring that up too. There's I think a new excitement around this intermediate range of vision. Right now we have other modalities. And we had the crystal lens many years ago. Of course, that gave us that intermediate range of vision. We also have other products, from other companies that have been made for that intermediate range of vision. And even going forward, I think we have other new devices or new lenses are coming out. We have the iPure by BVI, the LuxSmart, the IC8, which is a kind of small aperture lens. So do you find that we're going to see more and more technology in terms of focusing on the intermediate range of vision more than giving you 100% all ranges of vision?
Absolutely, and I see it even in the categories, again, of multifocal versus extended depth of focus. Patients want more intermediate vision. They're working, again, like I said, dashboards, eating, computer range. And even my patients who read a lot often say, oh no, I read on a tablet. I read on an iPad. So even when they're voracious readers, they're still using their intermediate vision. So for the lenses like iPure, lenses like IC8, they use different technologies to enhance that depth of focus, whether it's a zonal asphericity and positive spherical aberrations plus negative aberrations. There are different ways of pulling this off to extend that depth of focus. And that's what these other lenses are doing for us.
Yeah, and I think it's funny. You've seen this evolution over the years of we want to give everything to the patient. At the same time, we realize there's a little compromise when you want to give everything to every patient as well. So I think having an opportunity to not have to stress about kind of quality of vision affecting them in a negative way, having dysphotopsias, et cetera, and feeling comfortable that I'm giving a monofocal lens is going to give them that range of vision, I think does help open up the category a little bit more for us as well. So it's exciting times. We're going to talk about another IOL study. This is a Fernandez study that was also published in 2021, and it's looking at the trifocal lenses, the AT Lisa by Zeiss, that was published. And this has been around in Europe for a while now, and they looked at 1 year data, but they also now looked at their 6-year data, and they compared their 6-year outcome data versus their 12-month to see kind of what's a long-term effects and what are the neuroadaptation abilities for our patients in these lenses as well. So I just want to talk a little about this paper as well. Just to remind everybody, there were 62 patients that were interviewed as well. They looked at the VF14 questionnaire, looked at spectacle independence, looked at dysphotopsias, and they looked at defocus curves as well. And the idea is to look at long-term stability of patients as well. So let's talk about this in general. Are you using a lot of multifocals in general in your practice right now?
I am. Yeah, I am.
So tell me about your thoughts on just overall rates of dysphotopsias and neuroadaptation. Is that an issue for you in general once in a while?
It is, and because it is, we actually discuss it with our patients ahead of time. Now that we have options other than multifocal lenses, including extended depth of focus lenses and enhanced monofocal lenses, I think it's an important part of the discussion ahead of time. Setting those expectations, looking for the type of patients who will accept some glare and halos afterwards for the benefit of having quite good near, intermediate, and distance vision. So I think self-selecting those is really important.
Yeah, absolutely. So let me ask you, how much of it is patient personality types? I mean, do you look at that? Do you have any way to kind of judge which is a kind of a perfect kind of quality patient who's going to offer this technology to?
We do. We have questionnaires for the patients. We really see how they respond to being asked those type of questions, what they desire, what they want. It can be somewhat overwhelming for the patients to get all this information, so we try to send some of it ahead of time, get an idea of what they may want. And then when they come in, they have a sense of what these lens types are, what they may want, and then I just kind of drive that conversation, because some aren't good candidates for multifocal lens, for example. As you know, if they have ocular surface disease or retinal problems, they really might not be as good of a candidate. We're splitting light in these cases with the multifocal lenses.
Absolutely. And I want to get to some of those because I think so much, we haven't seen a significant increase in the adoption among our colleagues on kind of AT-IOLs and especially multifocality. It's kind of been more stable throughout the last few years. And so I think there's a potential for more patients who could benefit from these lenses, but there's that fear factor as well. So we'll talk more about that in a second. But let's go into the study real quick, and I want to talk and ask you some questions about, I know we don't have the AT Lisa trifocal here, and I know Zeiss is working on their monofocal lenses in the United States, which will be the same platform they'll put their multifocality on. But let's talk about the data. If you don't mind kind of running through this with me. This is the 6-year data from this study looking at their distance, uncorrected and corrected vision, intermediate, as well as their near. So kind of walk us through this if you don't mind.
So big picture, first of all, what I learned from this study is at 6 years, the data was as good or better than the 12-month study or arm, which is really important for this lens especially, because this is the one study, but maybe in general with multifocal lenses, and we can go through why that may be. But in this study in particular, it showed how at the 6-year time point of these patients, the data of distance visual acuity, intermediate visual acuity, as well as near, uncorrected, and distance best corrected, was better than the 12-month study. And we're always concerned about this long term, because do patients' eyes change over time? Do their refractions change as their eyes age? Again, do they have more ocular surface disease, retinal problems? They don't have less over time, dry eye, those kind of things. So it's very reassuring seeing that the distance, intermediate, near vision really hold out for that many years after placing a trifocal lens.
And what are your thoughts on just overall, in this whole category of multifocality? When you look at the data here, just looking at their 6-year performance, saying 42% of patients had 20/20 uncorrected. People think, well, that's not 100%. What are your thoughts on that? Is that number? I know we can't compare to other lenses, of course, but what are your thoughts on this data overall? The almost 50% of patients not needing any, or being 20/20 rather, without correction.
Again, first of all, that's something we talk about with patients. When we talk about their chance of being out of glasses, we never say it's 100%. We say you may need glasses for up close occasionally or for distance. Vision might be quite satisfactory daytime, even in the evening, but if you're driving in an unfamiliar area, if it's really dark out, if it's kind of inclement weather, those kind of things, then you might want some benefit of glass afterwards, just to set those expectations. And therefore, with these numbers, patients understand that it may not be 100%, but they're better off than if they didn't have it in the first place.
Absolutely. And you have to also understand kind of where they're holding their reading, right? Is it 12 inches, 18 inches, 16 inches? And that's also variable for every patient. So when they say they don't need glasses, it depends what they're trying to read and kind of with normal activity and how close they're holding it to their eye. And also, I think it's really important to recognize you still have good distance quality vision. You know, almost 50% had 20/20 uncorrected vision as well, and about 93% had 20/30 or better.
So part of this is also talking about patient satisfaction.
Absolutely.
So the VF14s, those kind of questionnaires, let us know how really happy patients are afterwards, and in this case, 6 years later. So I think that's kind of key too. What is the performance of multifocal lenses, in this case specifically the Zeiss lens, at a 6-year time point?
Absolutely. If you look at, to your point, this is the kind of a patient-reported outcomes, the PROs here. And you see about 95% of patients had a mean score, or it was 95 rather score of the VF14, which is very good actually. 85% of patients said there was no difficulty for all tasks, except for very small print and driving at night, like you mentioned, which is I think typical for any of these kind of lenses in this space as well. But to me, what are your thoughts on that? 85% had no difficulty for all tasks.
So this is what we want to learn from these types of studies: how to set those expectations ahead of time. The lens itself isn't going to change. We're learning how the lenses work. So in this case, at 6 years, we know how it works. So we learn, as I said before, that maybe we tell them occasionally you may need reading glasses for up close, or occasionally you may need them for distance. You're not necessarily throwing away your glasses because patients are going to have variable outcomes. But almost 90% had a level of satisfaction that they would do this again, even 6 years later.
That's great. Yeah, 90% would choose the same lens, and also I think 93.5% were satisfied with their kind of distance, intermediate, and near vision as well. So I think that's positive for us, because we always wonder about these lenses, and you know, if you're getting started with these lenses, you're wondering what's going to happen in 2 or 3 years. Am I going to be stuck with this patient coming back saying I'm not happy? And I think the stability of their daily functioning with these lenses, I think, is really important with this 6-year study. Any pearls that you have on identifying patients? So for instance, what kind of diagnostics, besides look at the ocular surface and patient personality and other pathologies, any other diagnostics, topographies, OCTs, higher order aberrations, are there anything else you're looking at?
I do look at a lot of those, because the level of astigmatism comes into play. We haven't talked about that. That's a lower, regular astigmatism is a lower level aberration, not a higher order, but lower order aberration. So that's key. So you really want to end up as close to plano as possible. So lower order aberrations first. The refraction, so the sphere, you want to get as close to plano, and the cylinder. So that's number 1 and 2. The closer we are for those, higher order aberrations come next. So first, you gotta have the right biometry so we get good results close to plano. Next, higher order aberration. So we want to evaluate for those ahead of time to see where they are and see if we can either improve or stabilize where those are. So a lot of diagnostics that we use on every patient that's going to get a premium lens. We perform those tests, multiple keratometry, tomography, topographies, those types of things. Look at point spread functions, determine spherical aberration of the cornea. Those kind of things are important into determining if these are good candidates or not.
And you mentioned OSD a few times, ocular surface disease. Will you hold on surgery and treat the surface first, and will you tell the patient, look, we're not going to do surgery right now, and wait for that stability of the surface to get better measurements?
We go one step further. So all the patients that come in, we advise, not everyone does it, but we have them for 2 weeks ahead of time on artificial tears and warm compresses to work the meibomian glands. And then they come in for their biometry. And then if the biometry doesn't look consistent, reproducible due to ocular surface disease, they go back. We may start them on an immunomodulator for a short period of time. But yes, I think it's critical that the ocular surface has to be as pristine as possible before we get the measurements. And then I think what we forget a lot of times is once that's done, we as surgeons are very happy. We got these great measurements, patients do great. What happens right after they have the surgery? They stop everything.
Yeah.
Oh, they're on an antibiotic, steroid, non-steroidal, but they stop the treatment for ocular surface disease. So I think in this age group, where these patients need to treat the ocular surface for another month at least afterwards to sustain these results.
Yeah, I cannot agree with you more. I think the surface is one of the most common reasons why we have dissatisfaction. Whether it's a monofocal lens, a multifocal lens, it doesn't matter. Quality of vision, fluctuating vision, and of course, neuroadaptation is more difficult when you have a surface tear film that's not healthy. Last thing I want to ask you, there's been some noise recently on high road aberrations, but also on angle alpha, angle kappa. So in other words, the center of the visual axis versus the center of the limbus or the pupil. What are your thoughts on that? Do you take that into consideration? Do you not? Because I know it's not a right or wrong necessarily.
I absolutely do, and there's a number of studies, as you know, on those too. But you do want to look at that angle alpha, angle kappa, as well as a chord mu, to determine if there's going to be a good fit, especially for a multifocal lens. I think the extended depth of focus lens is probably a little more forgiving in that regard. But we do look at that every patient, and that's part of the printouts we have from our topographical devices.
Yeah, no, absolutely. First of all, I just want to say thank you, everybody, for logging in or checking us out here as well, the Innovations Journal Club. I'm so thankful to have Jim Katz, my good friend. Please stay tuned for another episode of the Innovations Journal Club. I want to thank you all for joining us, and thank you to Jim, and be safe and healthy.
Thanks.
Thank you.